Good morning, one and all. I, Dr. Smarnika, the part of digital team of IAP and as well as the Goa State Coordinator for IAPWC Goa, would like to welcome you all to the 36th webinar of IAPWC Goa. This time we are doing a series of webinar on gut health, which is a very important thing and relatable to everybody. So in Ayurveda also, it is very much understood that most of the diseases that crop in our body are due to the gut health. So either the absorption of vitamins or minerals are not happening properly, or the toxic substances in the body is not able to go out or release itself. And that is the reason why we end up having most of our problems, which is very much relatable even in the modern science. So we thought of addressing the gut health. So last week we have done a webinar on the toilet ergonomics and the importance of using Indian toilet while squatting and how it is improving our gut health. This time we thought of getting the role of physiotherapy in the gut mobility. So we are basically doing a topic on role of physiotherapy in improving the gut mobility. When I thought of this topic, I could think of nobody other than Dr. Dhara, who is a pioneer in the field of pelvic floor. She is a pelvic floor specialist, and I could really not have any other word than having her over here. So I would just like to give you a slight introduction for Dr. Dhara. So she is the pelvic floor rehab specialist. I know I would be reading it, but I don't want to miss out on any of the things that she has achieved. I'm really, really proud of her as a physiotherapist as well. So she is directly trained by Dr. Hayat sir, who is popularly known as the father of modern pelvic floor rehabilitation in India. And so she is handling the post of the chief clinical instructor. She's also a team leader for the teachers training program in WOW-IPRI. She is heading the department of pelvic floor rehabilitation, and the head office is in Ahmedabad. When we come to academic contributions, she is herself a PhD scholar right now, and she is a lead assistant to Dr. Hayat Desai sir for designing, developing pelvic floor rehabilitation workshops and seminars for physical therapists, gynecologist, urologist, urogynecologist, physiatrist, sexologist, oncologist, oncogynac, colorectal surgeons, and more. So I think it's a very proud thing that we as physiotherapists are training them, which is really the need of the hour because we understand the pelvic floor better in terms of the muscles. She is the lead proofreader in the MCQ developer and organizer for one of the best books in the pelvic floor rehabilitation for doctors, that is Hayat's Manual for Pelvic Floor Rehabilitation. Lead assistant in research and development of under patent pelvic floor products like VEase, VFit, and WOW group of mobile app. I think she'll be able to guide us better with those things. Also, lead assistant in research and development of the final phase of the Hayat's MMT. It's a very interesting MMT. Everybody should know about it. She is a key contributor in designing the Hayat's FSF, that is the female sexual function, and also Hayat's MSF, which is the male sexual function scale, and chief executor in designing clinical educational videos for male pelvic floor rehabilitation. Again, something that we speak very less about. When we talk about pelvic floor, our main concentration always is related to the women's health, but no, it is related to male also. And that's how we thought that when we talk about gut mobility, it is a generic topic. It is not a topic about male or female. So without much ado, I think I should give the floor now to Dr. Dhara, who is going to take us through the pelvic floor, who is going to talk about the gut mobility. So thank you so much, Dr. Dhara, for accepting this invite. And I would like to now give it out to you. Thank you.
Thank you very much, Dr. Smarnika, for this such a lovely introduction. And thank you for organizing and constantly, working for giving those topics to the students and to the physios, which are really less addressed and which are really not very well spoken about. I would really like to thank Dr. Sanjeev Jha sir and Dr. Ruchi Varshney ma'am for giving this opportunity to other physios to understand and develop into the field of physiotherapy, and for their tremendous work in physiotherapy. I would also like to heartfully thank Dr. Desai sir for bringing this topic so widely on the floor that now people are taking that courage to talk about it. Yes, it was his vision that to break the cultural taboo and to make this pelvic floor, this ultimate health, accessible to every single person. And I'm so happy to see his vision coming true, that now people are coming forward and speaking about this underserved and less talked topics. And thank you once again, sir, for giving me particularly this opportunity to be in a part of your team with a very wide and great vision. So I'm starting my screen share. So in this in this 1 hour topic, I would really like to give you an gist on what, as a physical therapist, can you do in improving the gut motility. So our agenda would be, I'll be giving you a short introduction of BioFeedback, who is our founder, Hetsa. What is gut motility? What is physiology of defecation? How does the pelvic floor per se affects the defecation and the causes of defecatory dysfunctions, defecation, what are different defecation dysfunction, key assessment, the only tool if you want just one single tool to help you understand the behavior of the pelvic floor muscle. So what can be done in that? What is the role of physiotherapy in improving gut motility, and in background of BioFeedback. So I would really like to start this webinar with introducing you all to Dr. Desai sir. I am really very happy and fortunate to be a part of his team, and I'm also very happy and fortunate to be directly trained under him. And it is his vision that is to break the culturally break the courageously break the cultural taboo, and to make the pelvic floor rehab, the intimate health, accessible to every single woman and every single man on globe through innovative technologies and services. And for the contribution which he has made into the field of pelvic floor, he is popularly known as father of modern pelvic floor rehabilitation. He is the author of Amazon's bestseller book, that is Hates Manual of Pelvic Floor Rehabilitation. And the proud moment for us is that it is the Amazon's bestseller in urology, a field of urology which is now ready to understand and accept the role of physiotherapy in pelvic floor and other related dysfunctions. So it is the Amazon's bestseller in gynecology and obstetrics and bestseller in physical therapy. To his achievements and academic contributions and other things, he's the chairman and founder of IPRI, it is International Institute of Pelvic Floor Research, Rehab and Education. And it is again a very proud moment for me to say that it has received certificate of recognition from Government of India, WOW Experience Research and Development, WOW Group of Businesses, World Pelvic Floor Organization, and Easy PFM Exerciser. To his intellectual properties, he has WOW PF360, WOW VSPA, WOW WEN, WOW Vagina Fit, WOW Vagina Dilate, and WOW Group mobile application. And to the academic contributions and the intellectual property, he has developed HSMT, which is beyond the boundaries of Oxford MMT, and it is being proudly introduced into the syllabus of Masters of Physiotherapy in Women's Health by Gujarat University. HITS FMT, HITS self-assessment, HITS providers protection guidelines, HITS reflexive result scale, HITS female sexual function scale, and HITS male sexual function scale. So going towards the topic of gut motility. Now, when we talk about gut motility, what does it mean? It means the peristaltic movement of your GI tract, this peristaltic movement, that right starting from your mouth till your anus. So whatever movement is occurring into the whole GI tract is considered to be the gut motility, and it is very much required to digest the food, to absorb the nutrients, to produce the waste, and finally to eliminate that. So when we talk about the gut motility, it's not just about the intestinal work, it's not just about the pelvic floor, it's not just about the abdominal pressures, but it is a combination of all these processes which occurs together in order to extract the energy and the nutrition, and then to eliminate the waste which is being produced throughout the process. So when we want to understand the role of physiotherapy into gut motility, we really need to understand the physiology of defecation. We might be now very much familiar with the physiology of micturition, how the urination occurs. But when it comes to defecation, we somewhere limit ourselves from exploring more into this field. So this, through this webinar, I really want to open you all the new gate where you can work as a physiotherapist for the different dysfunctions like constipation, irritable bowel disease, pelvic dyssynergias or dyssynergic defecations, fecal incontinence, and lot more. So before going to that, the basic understanding of defecatory physiology, we should all know. So when we talk about the process of defecation, it is like whatever the food you have taken, taken it. It has been said that it almost takes 90 minutes, 90 to 120 minutes to pass through the stomach, then the small intestine, large intestine, and come to the rectum. But we do not, what if we talk about the frequency of defecation? The frequency of defecation is anywhere from 3 times a day to 3 times a week. Okay, but if it is less than this, that can be considered as a patient who is suffering through constipation, and along with if there is an hard stool. So there are different criteria to put them into constipation. But when we talk about the physiology, so what happens that whenever the food which has been accumulated into the colon is then being propelled to the rectum, so through the peristaltic movement and to the colonic mass movement. So the food is being propelled, the wastage is being propelled into the rectum. And when the rectum is full, I would really like to add one thing over here, which came out while discussing with a very senior practicing pediatric surgeon, that we were discussing a case, and this thing came out that the rectum and the uterus, these are the two organs in the human body with an enormous expandability. So the uterus can expand throughout the 9 months to have a baby inside. Similarly, the rectum also has a very good expansion capacity. So whenever the rectum is full, that will lead to the stimulation of the mechanoreceptors of the rectum. So these mechanoreceptors would be stimulated, which which will send the stimulation towards the higher cortex. That will be the urge to defecate. This urge to defecate is very important to be addressed. Otherwise, it can also lead to defecatory dysfunctions. So whenever there is an urge to defecate, so that in response to that, the internal anal sphincter opens. That is an involuntary muscle fiber. The internal anal sphincter is an involuntary muscle. So it opens, and whatever the feces is there will come and get accumulated inside the anal canal. Now, if you are into an appropriate position, and if you can use the washroom, the next thing which happens is the rectal pressure increases, the puborectalis and the external anal sphincters. This is exactly where our role will come. So we need to understand this part the best. The puborectalis and the external anal sphincter, these are the two skeletal muscles which are also a part of pelvic floor muscles. So these two muscles, they relax. Okay, and when they relax, they allow the passage of the stool and defecation to take place. Okay, so the important thing which we need to understand into the physiology of defecation is, it's not just that whenever you get an urge you sit and you void it, or you defecate. It's like whenever you get an urge, if you find that place is acceptable, you will sit, the rectal pressure increases, because the stool which has been formed would not be liquid. Majority of us, we fall under the criteria of type 3 or type 4 Bristol's classification of stool. Okay, so that is the class type 3 or type 4 Bristol. Generally that is the consistency of the stool. Okay, and when you have to pass that stool out, you really need to have an intrarectal pressure increase, intra-abdominal pressure increase, and simultaneously relaxation of the puborectalis and the external anal sphincter. So now you can understand that if there is any dysfunction in any of these, either the rectal pressure is not increasing, or the abdominal muscles are not working properly, or the pelvic floor muscles are unable to relax, or there is a nerve involvement, that can lead to a defecatory dysfunction. Okay, so this is the next slide, which I would really like to explain you in detail, because as I'm repeatedly saying, this is the point where we will be just a moment. So this is the Pubo rectal sling. So this is exactly where we would be working upon. Okay, so let me have you understand this once again. So if I'm just this, like, consider this to be a colon, a part of a colon, okay, the rectum and the anal, and this as the pubo rectalis ring. So now what happens when you do not want to defecate? Okay, when you do not want to defecate, at that time this would be pulled like this. Okay, so this is consider my right hand as the pubic symphysis. So the puborectalis would be tight when you want to maintain a fecal continence. Along with the external anal sphincter contraction, the puborectalis is also tight, and it is maintaining the the anorectal angle and not allowing the defecation to take place. So whenever you want to defecate, along with the other physiological reflexes which are working, you need to really relax the puborectalis. Once the puborectalis is relaxed, it opens up, it increases the it makes the rectum and the anus come more into congruity, and then along with the release of the external anal sphincter, you can defecate better. Now, where exactly the location of the puborectalis and the external anal sphincter is, so I would like to show it on a model. So this is my pelvic model. It is always with me whenever I'm taking any webinars, one of the favorite model of mine. So you can see this is the pubic symphysis, and this is the coccyx, and here is the ischial tuberosities, the right and the left ischial tuberosity. So this diamond shaped muscle is the pelvic floor muscle, and you can see here this is the external anal sphincter. The external anal sphincter is externally, and the puborectalis is this muscle. So if I'm just opened it so that you can clearly understand. So you can see this is the external anal sphincter here. This is the external anal sphincter, and if you see the opening, this is the anal opening. So this is the puborectalis. Okay, the puborectalis. Not going in anatomy in detail, otherwise we would be it will take 1 full hour understanding the anatomy. It's that beautifully designed. So you can see this, I'm just making. If I'm holding it in this way, this is exactly how your puborectalis is attached. Okay, so if it is tight, you understand, if it is tight, it will pull and it will not allow the defecation to occur. If it is relaxed, it will allow the defecation to take place. So this is the puborectalis. This is the puborectalis, which loops around the rectum. So now when we talk about the defecatory dysfunction, so you can see the okay, this is a tight puborectalis, and this is when the puborectalis is relaxed, the external sphincters are open, and the defecation takes place easily. But this does not happen if the person is suffering through some defecatory dysfunctions. So before understanding the defecatory dysfunctions, what are the causes for this defecatory dysfunction? Okay, so it can be, so now with the by understanding the defecation physiology, the thing which might be clear to you is that it's not just one system which is working. It is a combination of the nervous system, the smooth muscle, the skeletal muscle, and the valsalva, the intra-abdominal pressure changes and the intrarectal pressure changes, which helps for all these, which helps for the defecation function. So if there is any restriction, or if there is any paresis of the smooth muscles, Okay, any condition which affects the smooth muscle functioning, gastroparesis or any of these, okay, or the smooth muscle behavior is altered, maybe because of repetitive infections, repetitive inflammations, or cancerous pathologies, that can affect the defecation. If there is a pelvic floor muscle dysfunction, your muscle is so tight. When we talk about the pelvic floor dysfunction, that means if the muscle, either the muscle becomes very tight, it becomes spasmodic, and so this, the puborectalis which you had seen just now, and the external anal sphincter, again, the pelvic floor muscle is a very big group of muscles. There are multiple other things associated. I'm not going in detail of all those things and keeping myself related to the gut motility. So when we talk about the pelvic floor, if you try to understand, if your puborectalis is tight, it is holding your sling very tightly. Okay, it's holding the this rectal chain very tightly, or the sling very tightly. It will not allow the defecation to happen. I'm really sorry, but can Dr. Melissa, can you mute yourself? I'm sorry for that. So when we are talking about the puborectalis, if it is very tight, if it is spasmodic, if it is painful, it is not relaxing, that leads to defecatory dysfunctions. Okay, if the external anal sphincter is tight, maybe because of a trauma, or maybe because of a natal cesarean, postnatal delivery, that is through a vaginal delivery and a severe delivery where the perineal tear has been extended till anus, and the anus is painful, it's quite painful, and it's not relaxing or not opening, that can affect the defecation dysfunction. When we talk about the smooth muscle motility, even during pregnancy, when the progesterone and when the progesterone hormone is high in number, it also leads to a sluggish or a reduced movement of the intestinal motility. It reduces the intestinal motility. Plus the weight of the growing uterus also presses and reduces the intestinal motility. The second we discussed was the pelvic floor dysfunction. Going to the third is an inflammation or an infection. It can be either a stress, anxiety, or a lifestyle disorder. Okay, so many of the time the constipation, which is a very much discussed or talked about topic, you know, Google says that almost 50% of its search is related to constipation. So it is a very humongous field which is more or less related to the lifestyle dysfunction. It has been said that when your physical activity is less, when a person is not physically active or is not involved, it follows a sedentary lifestyle, there are high chances that the gut motility also reduces. So the first thing you need to understand is, if you are when your lifestyle is sedentary or you are not into an active lifestyle, it's not so that only your skeletal muscles or your fat is working abnormally, but even your intestines, they are compromised, their function is being compromised. Okay, so a lifestyle disorder can also lead to a defecatory dysfunction. A neurological involvement, any neurological involvements, maybe paraparesis, quadriparesis, Parkinson's, multiple sclerosis, any neurological condition, because it will directly affect the nervous pathway. Okay, or a trauma, an accident, or a congenital deformity like cloaca or anorectal malformations. So anorectal malformations are cloaca. These are the conditions where the newborn is born without a proper gut opening. I mean, they might have an absent anal opening, they do not have an anus at all, or they have a very small anus which is not properly developed. Okay, so these congenital abnormalities are also a condition where the gut motility is generally affected, and the only option for these cases is a repair or a reconstruction of the anus. So it is a very again, the pediatric population, they suffer a lot, because these types of dysfunctions, the anorectal malformation, these would require a life-saving surgeries in the initial hours after birth. So they might have to go for a colostomy earlier, and then later, when the baby is 3-4 years, or 3 to 4 months or 6 months of age, they go for an anal reconstruction. depends upon how much is the involvement. Sometimes even the genitals are also not very well developed along with the anus, so the surgery has been further planned, what reconstruction and how much is required. Okay, but anorectal malformations are also the conditions where they present with a defecatory dysfunction, because you can understand that if the anus is not present, if the anus is not present congenitally, and if you have to reconstruct an anal opening, okay, so the reconstruction has happened over here, over this area. And as we all know, it's not just the smooth muscle which plays a role, it is the skeletal muscle also. So the body was, the anus is been created artificially. You imagine that there is no anus, and now they have pulled the sigmoidal colon down and they have deconstructed and they have created the artificial anal opening. So even the pelvic floor muscles which are guarding the anus are not trained, okay, because that was a developmental issue, that was a developmental deformity. So the pelvic floor muscles, they might not have they might not be ready to function the way they are functioning in normal toddlers or normal kids. So in this case, the patient might present with an fecal incontinence or an overflow incontinence. Yes, overflow incontinence does not mean only a urinary issue. Overflow incontinence is the term which we are also using for the for the patients who are suffering with a fecal dysfunction. Okay, so the pediatric population specifically, when they are constipated, so the chronic constipation also leads to overflow. Okay, the chronic the rectum which is filled with the hard stool. Now when the new stool comes into the rectum, the less hardened stool comes into the rectum, this constant bearing down or constant pressure on the anus leads to weakening of the anal sphincter and leads to a fecal incontinence, that is an overflow incontinence. Okay, for certain pediatric population, it also compresses the bladder anteriorly. So you can understand that uh, if the rectum, as I already mentioned, the rectum has an enormous enlarging capacity. So if it is getting enlarged more than required, it can compress the anterior structures, and that can also be one of the cause for nocturnal enuresis or bedwetting in the pediatric population. Okay, so congenital anomalies or these type of there are many other causes for gut dysfunction or defecatory dysfunctions also, like for example sleep disturbances, inadequate healthy, you might be eating healthy food, but the pattern in which you are consuming food is not correct. Today you had a meal at 12 o'clock, tomorrow you are having at 3 o'clock, again day after you are having at 2 o'clock. So the timings when you have to eat is not being followed regularly. Okay, so there are multiple different causes for defecatory dysfunctions, and if we want to differentiate the defecatory dysfunctions, so we can more or less differentiate them as constipation to be termed, as I already mentioned, the normal frequency for the gut mobility, or the normal defecatory frequency is 3 times a day to 3 times a week. You can fall anywhere in between. Okay, the average being once a day for 7 days for every day. Okay, now if a person is complaining and coming up and saying that they are having motions only twice a week per se, and those motions are very hard, it is very painful, they have to strain, they have to put a lot of strain while they are passing, and even after passing they feel that they have abdominal blotting, they have, the rectum is still full, it is not been emptied completely, and it is very painful. So these are the few of the signs and symptoms which will help you diagnose them to be constipated. Okay, another, constipation is also a term which is very widely used but very less understood. If you are passing every day and your stool is hard, you might not be constipated, you are just suffering through hard stools. So in that case, your management would be more towards the fibrous. It might not be that rigorous. That is what is required to be for a constipated patient. Okay. The next thing to be is the fecal incontinence. The fecal incontinence means leakage of feces. So if the leakage of feces can be either the feces is so semi-solid or so much liquid that you are unable to hold it in the presence of a weak pelvic floor. So that can lead to a fecal incontinence, or it can be diarrhea. Diarrhea is increased frequency of defecation. Okay, fecal incontinence means leakage. There is a difference between incontinence and diarrhea. Diarrhea is related to the frequency of defecation. It might not be associated with incontinence every time. But yes, if there is a weak pelvic floor, or if eventually the person becomes weak and is unable to control, it can even lead to a leakage. Okay. And then is the dyssynergic defecation. Dyssynergic defecation is the term which is used when there is a dyssynergia between the three structures, means between the three processes. The intrarectal pressure is increasing, the abdominal pressure is also increasing, but the pelvic floor muscles are not relaxing, or they do not know how much to relax. They when you want to pass the when you want to pass the stool, okay, your pelvic floor muscles needs to relax completely. But if it can even happen that maybe because of pain, maybe because of a chronic condition, the muscles are so tight that they are not able to relax, or they are relaxing and again going into contraction. So they are not completely opening for the defecation process to take place. So then those are the conditions which fall under the category of dyssynergic defecation. Okay. One of the major reasons for defecatory dysfunction is irritable bowel disease. So, but irritable bowel disease or irritable bowel disorder is also been categorized more related to a psychosomatic involvement rather than an actual infective involvement. Now, when we talk about the exam, by now we have at least understood that what is the physiology of defecation, how the defecation happens, what are the pelvic floor muscles involvement and how they are being involved, what are the different causes of dysfunctions. So then the next thing which comes is how as a physiotherapist shall you assess those dysfunctions. So if you are seeing a patient with a say constipation or a fecal incontinence, what at least the basic guidelines or basic assessment things you need to understand. So we can specifically differentiate the assessment, the physiotherapy assessment, into two broader categories. One being the general physiotherapy assessment and another being the pelvic floor assessment. So when we talk about the general physiotherapy assessment, it means that you need to check everything. You need to check the physical fitness of the patient. You need to check um, the overall functioning, the abdominal muscle strength, the core stability, the core strength, the overall fitness of the person, lifestyle, what is the dietary habit, what is the appetite, what is the water intake, okay, what type of food the person is consuming, and what is the regularity in the food consumption. So that along with the general physiotherapy assessment, where you are checking the mobility, the flexibility, the agility, the power, and the cardiovascular endurance of the patient. Okay. And along with that, so that was a general examination which will give you an overall idea that yes, what part is involved. Maybe the patient is constipated, but the patient is suffering through the paraparesis. So the abdominal muscle strength is also compromised along with the pelvic floor dysfunction. Okay, that's why it's important that you have to modify your assessment according to the patient whom you are seeing, or according to the patient whom you are examining or assessing. Okay, the next thing comes is the more localized examination of the outlet, the exact area through which defecation happens. So that is the anus. Okay, so when you are examining the anus, so at that time you have to observe for the fissures, for the hemorrhoids, for the piles, for any other fistulas or any other dysfunction at the anal opening. And secondly, you need to examine the functioning of the pelvic floor muscles. Are the muscles tight or the muscles weak, or they are incoordinated? Okay. So maybe the person is suffering through a constipation and he is a normal healthy adult and still he is suffering. So why is he suffering? Does he has a localized issue, a pelvic floor dysfunction? If that is the case, where the pelvic floor dysfunction is in problem, then you need to assess it more locally. So the best way to assess, the first thing which you, if you are seeing your patient for the first time and you really want to get an idea of how the pelvic floor is functioning, there is a lot of depth of pelvic floor assessment. We do assess pelvic floor according to the clock. We do go for endurance testing and everything, but as I said, I cannot emphasize on all the things in 1 hour. So the easiest method to at least start the examination would be by checking the pelvic floor muscle MMT. Okay, so that is the manual muscle testing. So the manual muscle testing, which has been commonly used, is the Oxford's grade or Oxford MMT. Okay, but if you understand this grade, so it is from 0 to 5, and this grade is been giving you an overall idea that how is the pelvic floor muscle strength functioning. Okay, how strong it is. Again, it is very subjective, as you can, as something which is weak for me might be moderate for someone else, might be very weak for someone else. So it's not giving uh, a more objective finding or a more specific finding to the muscle involvement. Okay, so this was been used so far, and it was been created into an era where no major inventions or no major interventions were being created. But now, as we are moving forward into 21st century, we really need to upgrade ourselves to use more developed or more recent assessment techniques. So the assessment technique which we are been using and we are been finding it's effective, that is the Hates MMT, which has been developed by Hates sir. Dr. Smarnika has already mentioned about Hates MMT. So it is a very beautiful technique which has been developed by sir, taking care of the limitation of the Oxford MMT. So the limitations, the two major limitations which I think now you can understand is the vagueness. Okay, no specificity or no specific no specificity. And another thing is, how can you assess a hypertonous pelvic floor? Hypertonous pelvic floor means a pelvic floor which is into pain, which is into spasm, which is into tightness, or which is unable to relax. Okay, so the Hates MMT sir has designed it taking care of these two limitations of Oxford MMT, that is to find the grade for a hypertonous muscle and to have a proper interpretation which might not vary from person to person. Okay, so which can give us a clear black and white picture of what the functioning is, how the functioning is, and what should be your assessment according to the grades, and your your treatment according to the grades. So let's understand Hates MMT, and I really wish that you all please understand it, and please at least you palpate your own self, because till the time you cannot heal your own body, we might, or you do not know your own body, we might not do a justice with our patients. Okay, so when we talk about Hates MMT, it is the grade which will give you an idea for the contraction of the pelvic floor muscles as well as the relaxation ability of the pelvic floor muscles, which is very important to plan to plan your treatment. So 0, I will read the grade and they'll explain you again. So 0 is the baseline tone, the normal resting tone of the muscles. So at present, I am delivering a webinar to you. You all are sitting and you are listening, or you are doing some other routine, your work, but you are not consciously contracting your pelvic floor. It is it is at a baseline tone, which is higher than the resting tone, and that tone is required to maintain the continence, to support the organs, and to provide the stability. Okay, so that is the baseline tone. Now from the base, when you start the examination and when you are checking up the patient, so when you are, so imagine this as the vaginal opening and this as the examining finger. Okay, so when at present, this is the baseline tone. Now when I'm asking my patient to relax, I need to assess your pelvic floor, so you relax. And on the command of relaxation, if she is unable to relax, she has pain, she has tightness, she has discomfort, and she is giving an expression that, no ma'am, please, it's very painful, I cannot relax, I cannot penetrate you, I cannot allow you to go inside, that means there is no penetration, inability to penetrate, that is -1. Okay, a grade of -1 shows that there is inability to penetrate. The muscles are so tight that they are not or so pain, or they are so much painful or in discomfort that they are not allowing the penetration to happen. That is -1. -2 means a symptomatic penetration. The symptom can be pain, tightness, discomfort, or any other symptom. So when now you have started the second case is, she's allowing you to penetrate, but she's like, please ma'am, don't go beyond this, it's very painful, it's very painful ma'am, please don't. So it is giving you an idea that yes, the muscles are into spasm, the muscles are into pain, and they are tight. So that is a grade of -2. That is a symptomatic penetration. That symptom can be of pain, tightness, discomfort, or any other. And a grade -3, where the penetration is very easy. So as soon as you, like when you're asking the patient to relax, she's relaxed, you are able to assess everything inside, and there is absolutely no symptoms. That is a grade -3, which is a asymptomatic penetration, which reflects a easy and a complete relaxation. Okay, then comes, once you are inside, so next thing is you have to check the strength. Till the time you were not inside, you had to check the relaxation. Are the muscles relaxed, or they are into spasm, or they are tight, or they are giving some pain or discomfort? Okay, so once it is inside, so now it is inside, and you're giving your patient a command to squeeze as if you're trying to hold the urine. Okay, on your command, it squeeze as if you're trying to hold the urine, and the patient is able to generate a pressure which is from either side. Okay, so there is a mild pressure from either side. Okay, it's not a complete pressure, it's a mild pressure from either side. That is a grade 1. On your command of squeeze as if you're trying to hold the urine. So if she's giving you a circumferential grip, so this you can see was a mild contraction from either side. This is a circumferential grip. So if you get a circumferential grip over your finger, it is a grade 2. And a grade 3 is a circumferential grip and then strong upwards and inwards pull against resistance. So if you feel this as the movement, so it is like this. Okay, so that is a grade 3. And resistance means you do not have to apply a resistance of your whole shoulder pressure. You're ultimately checking the pelvic floor muscles, you're not checking a quadriceps ki utna pressure dena hai. So you need to understand that how much pressure, it's just a mild pressure. Okay, so and strong upwards and inwards pull against your resistance, that is a grade 3. Okay, so you can assess your patients to check for their pelvic floor functioning. So repeating the grades again, 0 is the baseline tone, -1 is inability to penetrate, -2 is symptomatic penetration, -3 is asymptomatic penetration, 1 being a mild contraction from either side, 2 being a grip with a complete circumference, and 3 is in strong upwards and inwards pull against resistance. So then comes the role of physiotherapy. So what as a physiotherapist can you do in patients who are suffering through gut dysfunctions, or who in which you really want to improve their gut mobility or motility? Okay, so in physiotherapy interventions, there will be few things like a diet modification, a lifestyle modification, pelvic floor rehabilitation plays a very major role, abdominal manual therapy, and the toilet ergonomics. So last Sunday, the topic which was being taken by IAPWC with Dr. Vishwaraj was on toilet ergonomics, and he had really explained it in a very nice way, that why is squatting more preferred than sitting, and what modifications can you do into your into your toilet habits. Okay, so the first thing being, because it is a 360 degrees approach, we cannot say that only the pelvic floor is the culprit, or only the diet is the culprit, or only the lifestyle is the culprit. It is a, you need to have an holistic approach to a condition. So you need to understand that what is the diet of the patient. Diet, it does not mean that the patient might be, as I said, might be consuming healthy food every day, but the pattern is irregular. And that is most of the time today's case scenario, that yes, I'm getting a tiffin from my home, but because of the uncertainty in my job hours, I at times had a food at 2 o'clock, at times I have it at 4 o'clock. Okay, so you shall not change your food habits or food timings this frequent. So you should there should be a good water intake, almost 8 to 12 glasses they say, but it is like 2 to 2.5 to 3 liters of fluid intake, water intake you should have. Okay, you need to add good amount of fibers and roughage to your diet, because that is ultimately required for the healthy functioning of your microbiota, your gut microbiota, or your gut bacteria, the good bacteria of your gut. So they thrive on the fibers and the roughage which you take. Okay, so that, and if your microbiotas, or if your gut bacteria, the good gut bacteria are healthy, they will help for a better gut motility. Okay, you should have good amount of fermented foods. So I am basically in Gujarat, and in Gujarat we have lot of fermented foods like dokla and khaman and xyz, but in southern parts of India they are using idlis, dosa, sambar, other preparations which of the fermented food. That fermented food is also healthy for your gut. Prebiotic food and probiotic food. Okay, so pre and pro, both these types of food, it is very much available from the legumes, the cereals, the fruits and the vegetables what you are consuming. So pre and probiotic foods, vegetables and fruits and legumes, cereals and pulses. You shall reduce the bakery intake or the fast food intake, that is a norm per se. And a healthy eating pattern, what I'm emphasizing from the very beginning, that what you eat matters, but how you eat and how regularly you eat also matters equally. The next thing is a lifestyle modification. As I said that a sedentary lifestyle does not only mean a stasis of your skeletal muscles, or a fat metabolization dysfunction, but it also means a stasis of your gut. Okay, so regular exercises or an active lifestyle is also a must when you talk about the gut motility or the gut functioning. Adequate quantity of sleep, okay, that is required, and a healthy habit and pattern of eating. Coming to the pelvic floor rehab. Now when we talk about the pelvic floor rehab, so in that, what is the basic understanding? See, no matter what the patient is suffering through, okay, they might be coming with irritable bowel disease, or they might be coming with, say, any other diagnosis, a congenital anomaly, or maybe post-cancer surgeries, or a reconstruction, or a repair. They would basically come with you with three different presentations. Either they would be weak, they means their pelvic floor, either their pelvic floors would be weak, or their pelvic floors would be very tight, or they would be incoordinated. So depending upon these three, whether it is weak, whether it is tight, or whether it is incoordinated, you need to plan your treatment. So if your pelvic floor muscles are weak, if they are typically coming up with fecal incontinence issue, okay, other rest of the functioning is good, but the major cause of dysfunction is weakness, then you have to strengthen the pelvic floor muscles. So those, and you have to specifically think about the anorectal triangle. Okay, you have to think about the anorectal triangle and not the urogenital one primarily. Okay, we are only talking about the fecal incontinence. So the weakness is over the anorectal area. So work upon strengthening of these anorectal area. You can go for transrectal strengthening. You can even assess the muscles which are weak anteriorly as well and strengthen them. So we are using a lot of strengthening techniques. It is by giving a mirror biofeedback, just an external feedback, and squeeze and relax, squeeze, okay, target that which area they had to squeeze and how they have to squeeze. And the urogenital is the one where they have to exert the pressure, exert the force. So squeeze, relax at that area. The second thing is you can even go for a clockwise strengthening. Okay, checking which area is more weaker and working upon its strength. Okay, you can also go for biofeedback technologies which are available. We are using BioPF 360, which is an external technology to work upon the pelvic floor function and strength. If the pelvic floor muscles are tight, or they are into spasm, or they are giving some pain or discomfort, then you need to assess that where is the tightness. Okay, how? So when you are going internally and you are assessing and the patient is saying that yes ma'am, this area is painful, or I have pain over here, it's tight, so you need to go for soft tissue mobilization techniques. Okay, you need to go, you even would require a puborectalis release. Okay, a puborectalis release, or external anal sphincter release, or maybe the coccygeus, also again a muscle, very important during defecation. Okay, coccygeus release. So these releases are equally important if the patient is suffering through pain, or she is suffering through tightness, or they are suffering through spasm. Okay, so that would come under a hypertonus. And third comes a incoordinated. Okay, so a bio incoordinated, or a muscle who is unable to relax when required. So in that, a biofeedback training of relaxation. Okay, biofeedback training of relaxation is important. So you can ask them, like when you are transrectal, you can ask them that okay, my finger inside, now you try to relax and let it fall out as if you are pooping, or as if you are defecating. Okay, so you relax and let my finger fall out, you relax and let my finger fall. There are even the technologies which are coming with a transrectal probe, where you ask them to, where they give a feedback to the patient that okay, you have to relax and let this probe fall out, relax and let this probe fall out. Okay, so even that relaxation and understanding, giving a feedback to your brain that yes, when I'm relaxing, this is the sensation which comes. So whenever I'm relaxing, so this is the sensation of falling or relaxing and letting the poop out or letting the stool out. So this exact thing I have to do when I am on the when I am defecating. So I do not have to tie it, but I have to relax and let it fall out, relax and let it fall out. So relaxation and understanding that what is the feeling when the stool comes out, so that is also important. So that also takes that also comes into the pelvic floor rehabilitation. And again, a good thing which the patient can do by their own is the abdominal manual therapy. So when we talk about the abdominal manual therapy, so as I said that you know the intestine, so this is the abdomen. So the intestinal motility or the abdominal manual therapy, there are lot of videos which are available on YouTube, where they are specifically focusing on how shall you go for abdominal manual therapy if you are suffering through constipation. Okay, so there are few strokes which you have to follow according to the colon direction. So how the colon moves, from right down to up to center to left and then towards the rectum. So the whole colonic movement, it has been shown on the YouTube. They preferably say that you should use a castor oil. Why castor oil? See, castor oil, when you consume orally, it is a laxative. So it increases the gut motility, the peristalsis. But here they are not saying that you consume it orally, but you apply on the skin. So they say that castor oil has a good absorption in the skin. It is a antibiotic. it is an antioxidant, it is an antifungal, and it is also a cleansing agent. So it will help to clean the area. Okay. So, but see, these are not this or this. These are the techniques what I'm discussing right now, the diet or the lifestyle. So it's not so that shall I go for a good diet and I skip a lifestyle. It's not like that. It's and diet and lifestyle and pelvic floor and abdominal massage and toilet ergonomics. Okay. So this is a 360-degree of, yes, if there is a medical intervention required or a surgical intervention required, then plus that as well. Okay. So when you go for an abdominal massage, they say that you have to follow the linings or the line of action of your intestine. Okay. So right lower to right upper quadrant, to transverse to left upper to right lower, so left lower, and then out. So you can go for an abdominal massage at your own pace, at your own time. Do not do it immediately after food. At least keep 2 hours of break before and after food when you go for abdominal massage. Your knees should be relaxed. Your your abdominal muscles should be relaxed. It's not so, it should not happen that when you are doing it, your abdominals are so tight that you are ending up in pain and soreness of your abdominals. Your abdominals should be relaxed. Your pelvic tilt should be neutral to a bit neutral to posterior, and then you use a castor oil to go for the massage, and even you can use a castor oil pack. So a castor oil pack is something like you apply the castor oil on your whole abdomen, then you can place a muslin or a cotton cloth over it. You keep a heating pad, cover it with a plastic, and then cover the whole preparation with a thick towel. So they say that when the heat is been applied, a castor oil along with a superficial heat is been applied, its absorption in the body increases. And as if its absorption in the body increases, so would be its function. Okay, so you can go for abdominal manual therapy, abdominal massage, or even castor oil pack as an adjunct to whatever you are doing, and that can be done by the patient at home. There are many self abdominal massage videos available on YouTube. And then is the toilet ergonomics. Okay, so along with the seating postures, like how shall you sit, it's also important that how much time shall you sit. So you should not spend more than 5 to 10 minutes into your toilet seat. You should not go with mobile, papers, and books. That is a place where you have to avoid, and you do not have to spend time there reading a book or a newspaper, or watching Insta and Facebook on mobile. If necessary, if possible, squat rather than sitting. Okay, squatting rather than sitting is always preferable, as it helps to relax the puborectalis better, and it helps to have a straight line, a straight curve between the rectum and the anus. Okay, no bearing down. Bearing down would lead to more of the this pelvic trauma and more of the long-term weakness of the pelvic floor. Try to relax. So instead of when we are, this is the common mistake the constipated patients do. So whenever they'll get a pressure, they feel that they're unable to pass, so they will bear down. And it's not so that they are just applying the force through the pelvic floor, they are literally applying the force throughout their body. So it's like, so this is just waste of time. Instead, take a deep breath in, relax, and let it pass. Need to understand the behavior of diaphragm and pelvic floor as well. We very well understand that when that you are exhaling, or when you are bearing down, instead of opening, your pelvic floor might contract, and it would rather worsen your constipation or worsen your symptoms. So instead of holding breath and bearing down, relax, open your mouth and breathe. Breathe and let the stool pass out. Okay. You can even teach a perineal splinting. Perineal splinting is, just applying. Many of your patients might already be doing it. So when they feel that the stools are quite hard and they are not coming out easily. So you can wrap a tissue and just apply some pressure over the perineum so that it does not give an unnecessary force on the perineum and the pain, specifically post vaginal deliveries, the tears. So the way we are splinting other scars or other sutures, you can splint the perineal sutures as well when you pass the stool. Okay, that was the last thing, I think. Yeah, and this was all about the gut mobility and this is not everything what we can do. We can really do more of hands-on work. We can really do good amount of modifications and other things, but this was an overall idea which I think would be helpful for you to understand our scope of practice as a physiotherapist in this, more uh, a field which is now becoming more and more important per se, because we shall not forget that the major role of intestinal health is also into immunity. So the better your gut is, the better your immune system would be. And we are also doing a lot of work into sexual health rehab. We are working upon the sexual dysfunctions as well, and how as a physiotherapist can you help for the sexual dysfunction patients. So this is just my next flyer of the upcoming workshop, webinar, if someone is interested. And you can also contact me directly on 8000521503. That is my WhatsApp number. You can drop a WhatsApp message if you want to know anything else related to the work we do, or you want to discuss any of your problems. So it is 8000521503 is my direct WhatsApp number. And let me give you a brief introduction of what WOW-IPRE is. So WOW-IPRE is International Institute of Pelvic Floor Research, Rehab and Education. It is an initiative of WOW Group by Dr. Desai sir, who is popularly known as father of modern pelvic floor rehabilitation. And sir has received, sir and his forms and innovations has received multiple certificates of recognition from Government of India. There are many businesses, non-medicals, medicals who might have received a startup, but WOW-IPRE, the big difference is WOW-IPRE is #1 for pelvic floor education, as it has received the certificate of recognition from Government of India with legitimate DIPP number to specifically train the physiotherapist to perform the specialized transvaginal transrectal pelvic floor rehabilitation, to train and place skilled pelvic floor rehab specialists, and to improve the physiotherapy education, employment, and businesses and services. We are a global brand. We are training across 7 countries, and all our concepts and innovations are being used into their clinical practice as well. We are in USA, UAE, Nepal, Philippines, Malaysia, Africa. Sir has also contributed into the field of pelvic floor rehab by writing a very wonderful book, that is Haid's Manual of Pelvic Floor Rehabilitation, which is also a recommended textbook in the Masters of Physiotherapy in Women's Health in Gujarat University. And it is the Amazon's bestseller, #1 in neurology, Amazon's bestseller in gynecology and obstetrics, and Amazon's bestseller in physical therapy. To academic contributions and intellectual property, it's HSMT, which we had just seen. It is specially been introduced into the syllabus of Masters of Physiotherapy, Women's Health, Gujarat University. HITS functional muscle testing and training, HITS ring clock assessment, HITS surf assessment, HITS providers protection guidelines, HITS reflexive result scale, HITS female sexual function scale, and HITS male sexual function scale. So the all assessment techniques what you need into pelvic floor, sir has innovated all the assessment tools in such a way that we can get a faster results to our assessment and a better goals to plan the treatment. The book has been also endorsed by many national and international dignitaries, like founder president of SEPHOG, South Asian Federation of Urology, and founder member of Gynecology Endocrine Society of India, ex-president and ex-vice president of FOXY, that is Federation of Obstetrics and Gynecological Societies of India, national president of Indian Medical Association, a United Kingdom lead consultant urologist, ex-president of Urological Society of India, past president of Endourological Society, past president of Society of International Urology, registered clinical exercise physiologist, American College of Sports Medicine. And to the innovations and intellectual properties, it is WOW PF360, WOW Women, WOW Men, WOW Group, mobile application, Easy PFM Exerciser. Other brands are like Easy PFM Exerciser, Video, World Pelvic Floor Organization, Weekend, WOW Exercise, WOW Experience Research and Development. And authenticity, as I already talked about, is Gujarat University has proudly introduced HSMT into the syllabus of Masters of Physiotherapy Women's Health. So thank you one and all for giving for coming and joining this war against silent suffering. Thank you to all of you from HSM, and a big thanks to sir for giving us an opportunity to speak about this untalked topic. I would also like to thank once again Dr. Sanjeev Jha sir and Dr. Ruchi Vashne ma'am for giving this platform of IAP, for spreading the knowledge all across, and Dr. Smarnika for rigorously and without taking a break organizing such wonderful webinars to uplift the knowledge. Thank you once again.
Thank you, Dr. Dhara. Can we have Dr. Riddhi to start the Q&A, please?
Thank you, Dr. Dhara, for such a wonderful presentation. The first question of the webinar is, does cycling or riding geared bikes cause any pelvic floor muscle issues?
Dr. Dhara, you can keep the screen share or you can answer like that, no problem.
I'll on it, but sorry, I didn't get it. Can you just repeat the question? Does cycling or
riding geared bikes cause any pelvic floor muscle issues?
See, now a very nice question that if a person is a cyclist or they are using a geared bike or they are into some sort of profession where they are using it, so it can affect the pelvic floor, it can affect the perineum, and why it affects is by a direct trauma. So many of the cyclists and when they are not been using the pelvic floor the way it should require, or when they are not taking proper care of the perineal area, that can lead to a trauma of pelvic floor. So it's not so it can affect, and how will it affect? Many of the studies are also showing that cyclists or dancers or athletes, they are found to have weaker pelvic floor. Okay, just to mention one such study, the study which was done on the gymnasts, they had shown that they do not go for water intake before their activity or before their performance with a fear that they might leak. Okay, so there is a chance of pelvic floor muscle involvement in all of the specified contact or non-contact athletic and sports activities.
Thank you, Dr. Dhara. The next question, ma'am, how can we assess tightness of puborectalis?
See, when you want to assess the tightness of puborectalis, so you can go both ways. So you can first check the HSMT and find out that what the grade the person is, whether it is a grade -1 or a -2. If it is a grade -1, that is there is no penetration, you need to first relax the superficial muscles. If it is -2, you need to palpate that where exactly the patient has pain, whether the patient has pain at the posterior segment, I mean the anorectal segment, and simultaneously you can even go for a transrectal work and check that when you are palpating. So this comes into hands-on skill. The more patients you would palpate, the more better your understanding will develop. So eventually your fingertip will work as your eyes. Okay, so this is what Hitzer always say, that when you are working transvaginally, transrectally, your fingertip should be your eyes. Okay, so when you will go and you will palpate, you can palpate transrectally also, that whether that is painful, or when you are assessing it, the patient is complaining it, ma'am, I'm feeling as if you're stretching something. So if that stretching wala feeling, if she is getting, or if it is tight, or if it is painful, that means yeah, your puborectal is tight.
Thank you, ma'am. The next question is, can we use Russian currents therapy for improving muscle strength? And can we do pelvic floor testing with Kegel exercises?
See, Russian currents, they are, when you talk about the electromodality or the current therapy, IFTs and Russian currents, they are really good to work upon a weaker pelvic floor muscles. Okay, IFT is also been used in order if the patient has pain or hypertonous pelvic floor, but it is equally good in treating the hypotonous pelvic floor as well. So Russian currents you can definitely use for weaker pelvic floor muscles. Talking about the Kegel exercisers too, I really do not know that whether they are being designed or validated to be used to check the strength. So if you get such articles, that is okay. But I would rather say that, you know, if you want to check the dynamic strength or if you want to check the functional strength of your pelvic floor muscles, so the what we are using is VFit. VFit is, again, it is a technology which is being used to objectively strengthen the pelvic floor of this dynamic functioning, or the you might have a muscle which is, you know, of a grade 1, 2 on or 3 even on HSMT. Okay, that is the static strength. But dynamically, when you have to check its functioning or when you want to check its response during a activity, you need to see that whether the muscle is dynamically also strong enough. So for that, what we are using, it is VFit. That is, if you want, you can ping me. I would personally share the details of VFit to you, or you can get its details in the book as well. So which will help you to objectify that how much is the pelvic floor weakness and the vaginal laxity. But yes, coming back to your questions, Russian currents, they are good for the pelvic floor muscle strength to improve, to work upon. See, it's not, again, I'm saying it's not this or this. It always should be this and this. Okay, yeah, you can use Russian currents.
Thank you, ma'am. There are no further questions.
Okay.
Dr. Melissa, please take over.
Yes, am I audible?
Yes.
Okay. So thank you, Dr. Smarnika. It is my privilege to bring forth the vote of thanks for today's webinar. Indeed, we all understand that physiotherapy is ever evolving, and today we have seen a new perspective. We are enlightened by all the information that you have shared with us, Dr. Dhara. Thank you for bringing about this awareness today. I, Dr. Melissa Lewis, on behalf of IAP Women's Cell Goa State Team, extend a very hearty vote of thanks to Dr. Dhara Shah for taking time out and gracing us for this webinar and sharing with us your valuable insights. I would like to thank the whole team of IAP Women's Cell Goa for organizing such a wonderful webinar. Last but not the least, I would like to thank the IAP technical team for their support and for providing this platform to reach out to our ever-growing physiotherapy community. Thank you, one and all.
Thank you, one and all. Thank you for giving us your time in the morning. Hope to see you next week with our next webinar, which is going to be on gut mobility, gut health again, which is the importance of yoga and how yoga can help us improve the gut mobility. Thank you.